Do you want to share a little bit about your story? Because I'm guessing our audience hasn't read
Yeah.
it, and kind of how that has changed to how you are as a physician and as an educator, because I know you teach residents in your job.
Yeah, I'd be happy to. Thank you for having me. My patient story really began at the end of my medical training. I was just finishing my pulmonary and critical care fellowship at Henry Ford Health in Detroit, and I was 7 months pregnant. I was out for a celebratory dinner, and I had the most severe acute onset of abdominal pain that I could have imagined. It was like this instinct kicked in that I knew that pain was going to kill me. And that pain was a result of a tumor that I didn't know I had in my liver that had burst. And it was something that caused me basically to bleed to death. I was fortunately resuscitated, but went into multi-system organ failure, lost the baby, spent quite a lot of time in our surgical ICU recovering from all of my organs that had failed. And really that set into motion a kind of 10-year patient experience where I saw us from the other side of the bed, things that I had been a part of, ways of communicating, lapses in communication. All of it was quite jarring from the patient perspective.
I loved how you said on page 63, at the intersection of a lack of control and absence of rigorous attention is distrust. And you said there are items left at the door when one enters the hospital, chief among them comfort, a bit of dignity, and any semblance of control. And I do. When you read it in black and white, it just makes so much sense about, oh yeah, the first thing we do is we take away their clothes and make them wear a gown. I mean, we strip them of a lot of identity and control. So is there a way that we as doctors can kind of help give some of that control back or help patients with that lack of control that they're feeling in the hospital?
I think that's such an important point. The depersonalization that's just sort of baked into the institutional structure of hospitals forces us to go a little bit further to get to really know who our patients are as people. I think our training really disadvantages us into believing that we are there for the medical aspect of this moment in time and nothing else is relevant except what's pertinent for this case or illness or acute exacerbation. And for our patients, that's just not true. They're coming to us as whole people with a contextualized life story before and what they hope for after this. The easiest thing that we can do is honor that story and get to know who they are truly as people, what their hopes for the future look like, what a good day looks like to them, who's important, who are they hoping to get home to, whether it's a pet friend or a person, what hobbies do they hope to return to. When we do that, I think we open up channels for connection that are nourishing to us as well, because now we're not, taking care of a diabetic ketoacidosis. We're taking care of a person with hopes and dreams and wishes.
Yes, and I know you, in one of the stories that you'd shared, there was a patient in the ICU that had the note cards and wanted the doctors to write to make, what are your hopes for this person? And I know one of your trainees had a hard time coming up with what they wanted to share because that was so out of their wheelhouse of diagnose and treat and follow this plan.
She taught me a lot. I'm happy to report that patient is still alive, and I just was communicating with her yesterday. She underwent a bilateral lung transplant and has been living her best life. She looks better than me. But at that moment, she was dying in our ICU, and we had very little hope that she would live to be transplanted. And so for her to ask us to write a hopeful message felt false based on our medical knowledge. And we had to really tap into the truth that you can heal even if you don't cure. that our proximity to her, our wishes for her, all of that was healing. Her religion was very nourishing to her. And we always keep that, on the side or out of sight. So she drew it into our line of sight, and I'm grateful for that.
And I know you talked about in your book, learning to sit with pain. Yeah. And the importance of acknowledging that emotion. Can you explain kind of what you mean to our audience? Like, what does it mean to sit with pain?
Yeah, my sort of personal journey in finding meaning in medicine has gone from a place where I used to believe that if I couldn't heal someone, that I didn't have value in their space, in their room, in their care plan. And what I came to understand is really, truly how much value we bring when we are just willing to sit with difficult things, when we are willing to be a container for suffering, to be able to say, I can't help solve this. I wish I could cure this, but I can sit with you as you go through it and navigate it alongside you. We're not taught to value just being present for suffering. And, I had a patient whose family really taught me that of everything I did as she died, it was just my willingness to sit with them and not deny their pain that really helped them to heal.
Well, you talk a lot about with the patient experience and patients with that lack of control, talking about anxiety and how you said in the book, we attempt to bludgeon the feelings into submission with data. And I've done that as a doctor. I've had a patient saying, I'm scared. I'm like, well, this is the percentage. This is your outcomes. And they're still anxious. And I'm like, I gave them all the information. Why are they still anxious? Because it doesn't respond to data. So how do we address that?
Yeah. I'm laughing because even though I know this now in my work life and I look for emotional cues in the form of questions, and I recognize that, that question is really anxiety. That question is really fear. That question is really distrust. And I address the emotion beneath it. I still do that very poorly in my outside of the hospital life. So when my husband was concerned about anesthesia for an EGD, I'm like, we do this all the time. The risk of complication. And I started citing data and I was like, wait, no, of course that doesn't work. I understand you're concerned. It must be scary to relinquish control to someone you don't know. These are the ways they'll keep you safe. I know what I need to say, and so often I don't.
I know. I remember a patient came in to see me for an ER follow-up, and they had a small amount of rectal bleeding. Their hemoglobin was stable. All the labs looked good. They were very young. Everything was very reassuring. And I couldn't figure out why they were so anxious. And I remember I had a student at the time, and I said, we need to find the anxiety. We have to follow the anxiety to find what's going on here. I said, we find that cause, then I can give her the right information and I can answer her quickly. We talked a little bit more and found out that her neighbor had recently been diagnosed with stage 4 colon cancer, and they started with, blood in the stool. And so that was the first thing in her mind is, I have stage 4 colon cancer and I'm going to die like my neighbor. And, after addressing it, we're like, no, actually it was just bleeding hemorrhoids. This is very benign. This is very easy to treat. But in her mind, she correlated those two. And if I hadn't asked that question, I don't think I ever would have gotten to, what are you scared for? So I think it's important for me to train my students. I say, look for that fear and then ask them about it and acknowledge it. I mean, you mentioned in the book, I love this quote, if we don't recognize emotion, we certainly can't respond to it. So, and fear is not responding to data. So we need to find that emotion, find the fear. I'll tell that all the time to my students, find the fear and then respond to that.
And the story, because the best medicine in the world doesn't work on the wrong story. So if her story is, I have cancer, they just haven't found it yet. And nothing will appease that until you know.
You talk a lot about seeing a patient suffering and acknowledge it. And then has that changed how you've trained students, or kind of talking about your Clear Conversations project? Can you tell more about that?
Yeah, Clear Conversations is something that we started at Henry Ford Health probably 10 years ago. It's inspired by Vital Talk, which is a national communication training program. We use improvisational actors as the patients, and we really take the trainees and the attendings through a simulated conversation, but simulated doesn't quite capture what it is. When you're sitting there in conversation with these very skilled improvisational actors, it truly feels like the experience of talking to a patient's family member. And that really allows for experiential learning. So we use cases that, we need to practice on before we experience them in real life, so that we limit the harm that can come, because we really believe that conversations are a procedure, just like any other procedure that we train for. Though they're all different, there are signposts you can look for and mark and plan for. You can know that giving information well means small chunks and no jargon, and pausing and asking what they've heard so far, if there's clarity in your communication, looking for opportunities to respond with empathy and compassion, and aligning with their values. These are things we should always do, but it's not something that's necessarily trained in school. So we've had to do that on the back end of it.
Yeah, I mean, because there's very different styles in physicians, and very different needs for patients. Some people like, just give it to me straight, don't
Yep.
sugarcoat it. And other people, they want a little bit more gentle approach. Don't scare me with all of the possibilities. Tell me what you think is most likely here. Some want all the information, some
Exactly.
don't want, hardly any information, or tell my family, don't talk to me. It's very individualized, which you can't just say the textbook is going to work for every single patient every single time.
Not at all. It's the intersection of those relationships where we can find healing. And I think for, students coming in, I want them to know that medicine really needs to bend a little bit towards them and allow them to be their full selves, because when we stay whole and we can function from that place, we really can be healers.
Thank you so much for talking with us. Like I said, I absolutely love your book. I've read it several times, and I find something new each time I read it.
Thank you so much.